Welcome, everybody, and thank you for the time today. Excited to talk through this with you. So provider supply and demand, something we've been seeing a tremendous amount of interest in as more and more organizations are trying to take a more strategic approach to figuring out how do we evolve our provider complement within our service lines, within our geographic footprint. How do we apply data elements to that? And one of the things that through my career, the last 15 years, that's really been ripe for innovation is really how do we think about utilizing, what was traditionally community need type data to really make strategic decisions about provider recruitment. And so for today's webinar, wanted to talk a little bit about, so I know we have some HSG dashboard clients that have access to provider supply and demand. I think some on the call may be evaluating what this is. So I want to do a little background on just what it is and how we think about it. And then basically do a walkthrough of the entirety of the kind of the workbook and all the worksheets within and talk about the data elements and when we might think about utilizing them. So that's what we'll go through today. As Kelsey said, if you have questions, drop them in the chat. We'll do our best to get them answered here on the call. And I'll try to notice them as we go along. And if there's anything that doesn't get responded to during today's session, we'll obviously be happy to follow up with you after the call. Okay. So again, as Kelsey said, I run our strategy service line. I've worked in doing all forms of manpower planning, from very broad kind of medical staff development planning engagements, trying to bring together, decision about provider recruitment making for billion-dollar organizations. I've worked down at the critical access hospital level. How do we figure out how we grow our provider complement in a financially sustainable way? So this topic's always been kind of near and dear to my heart. If there's anything that you would like to ask me personally or talk about your specific situation, my Calendly link is at the bottom of slide 4. When we think about why we went down the path of developing this provider supply and demand kind of data visualization for our HSG dashboard customers, as I said, we've really been in the space for like 15 years, thinking about how do we help organizations make strong recruitment decisions. How do we decide when we recruit versus how do we ramp up into our own internal capacity? How do we prioritize specialties against one another? How do we prioritize markets against one another? And so while everything that we're going to look at today is not how do we fully answer those questions, the provider supply and demand data that we're going to look through today really is one critical component of understanding the market and being able to assess, kind of what our opportunities are that we might want to prioritize. So kind of jumping in, first we're going to talk about just what is provider supply and demand from our definition of that workbook, and then I'll kind of do a run through of all of the worksheets, and then we'll talk a little bit about for our current customers in this space, kind of where we're going from a product roadmap perspective and what updates you can expect to receive in the future. So starting with just some housekeeping. So one of the things we've learned as a healthcare data analytics visualization company is it's really hard to create demo versions that everyone can look at without showing too much of any one of our clients' data. So we built a demo version that attempts to blind as much data as possible. So while your worksheets will probably look the same, you definitely will have the same worksheets available to you if you're looking at it on your end and you have your version of provider supply and demand open. This is the version we're going to look at. It's going to look a little bit different, but the content should all largely be the same. We are working to, as we have a number of clients kind of on different cadences in terms of when we last built out your provider supply and demand, we're going to work towards getting everyone to the same version around your next annual update. So some of the things that we look at in here, if you haven't had an update done in a long time or you're not on an annual update cadence, some of this might look a little different than what you have. But the next time we do an annual update for your organization, we're going to bring everybody current to what this current version looks like. Okay, So starting off with when we talk about what is provider supply and demand. So when we think about this is really the supply and demand and succession planning data that we've tried to make as visual and strategic as possible, focused on. I'm looking at the first bullet here. Really ambulatory specialties. So sometimes we get questions about hospital-based specialties and what do I need in terms of emergency room coverage or in terms of hospitalist coverage or laborist coverage or anything like that. And that's really kind of a different model when we think about what do we need there. So that's really kind of hospital-based volume. What we're looking at here is really kind of ambulatory, focused on kind of what populations exist in the market and how many physicians or advanced practice providers are within the market serving that population. So when we do provider supply and demand, it's all non-pediatric ambulatory specialties, meaning we can, but we don't typically go into things like pediatric cardiology or pediatric nephrology. But we do look at pediatric primary care. And then, when we look at that data, we frequently, as most of you do as well, put this provider supply and demand data alongside, where are we from a market share perspective on the inpatient and outpatient side? What are our growth goals? What are we trying to move to from our current position in the market? What are we trying to grow into from a market share perspective? What does our internal access and capacity data look like? So, we obviously always love recruiting new providers, but we also want to make sure we're effectively ramping up our existing ones and we're utilizing, kind of our ability to grow internally before we make expensive investments in providers. So we want to look at that data. And then we also want to look at all this data kind of in the context of our organization's strategy for growth at the enterprise, highest health system level, as well as kind of at the service line level, market level. We want to make sure that, as the organization has set a strategy, that we're thinking about all these data points kind of in the context of where are we trying to go. And we're not looking at things like provider supply and demand in a vacuum. And I say that because I think it's less prevalent now than it was, say, 10 years ago. But I used to walk into, conference rooms all the time, and we'd be talking about provider supply and demand with maybe our provider recruitment arm and maybe a handful of physicians and maybe, 1 to 2 executives, but they were kind of making decisions kind of on their own. Well, what does the community need data say? What does it feel like we need? Versus, how do we kind of holistically integrate this type of data, really thinking about our provider growth with our organization strategy. So that's really the context in which we think this data should be utilized. When we put provider supply and demand data together, typically, and for most of our clients, unless you ask us to do otherwise, we typically do a 3-year lookout. So we're looking at population growth rates over a 3-year period. So if we were completing your provider supply and demand data today, we'd be projecting the population through 2027. So for some markets, especially markets that have some submarkets with really, high growth, especially like outside urban areas where we see, different suburbs, tend to grow at double-digit rates. If there's a strong local economy, that's really important to look out and kind of project demand as opposed to just looking at it. What is it today? We have done further looks out. Typically, don't want to go further than 5 years. 5 years feels, where it starts to get a little. We can look at what the population growth might be, but it's really hard to kind of think about our 4th and 5th year of our recruitment plan. But all can be done. So when we do provider supply and demand, so we typically use two types of market definitions, and I'll start with the bottom one first. So some, but not all organizations request us to do their Stark 3 market. So that's the compliance-driven definition defined by Stark, that says if you as a nonprofit health system are wanting to do a financial transaction with an independent or private practice in your market to help them support recruitment, that we have to justify community need for that specialty, and that provider, that incremental provider that we're helping support, has to be placed within our Stark 3 market. as most hospitals have gone to a heavy employment strategy, and the remaining independent groups in the market are really strong, and they're independent because they're financially able to support their own growth. We're seeing more and more organizations not really interested in even looking at that data. But for a number of organizations, they still utilize it. There are some markets where it makes sense. So that data is available. But more importantly is how we think about our strategic market. And so for a lot of organizations, strategic market means primary, secondary, tertiary, right? The market that we immediately serve, the market that we hope to draw patients from, towards our facility and our campus, and the tertiary market where, patients kind of go everywhere and we're probably not the dominant player. We tend to, and I'll do a slide on this later, but we tend to try to push organizations towards, let's really think about our market strategically. Let's not treat the northwest corner of our market and the southeast corner of our market that both may have a secondary market definition as the same market, because we're likely talking about very different populations traveling for care in very different ways with very different competitive dynamics. And so we're happy to take in your organization's strategic markets if you have those types of definitions. We're also happy to kind of coach your team through how might we strategically look at your market, so that as we kind of segment it and think about, what our footprint needs to be in each market and how are we competing for patient lives in each market, that it makes sense as we apply the data to it. So to generate provider supply and demand, we do a couple things. So one, we do a comprehensive provider inventory. So when you look at your supply and demand data, the supply data is generated by us pulling in data from three sources. One, we ask our clients to tell us about your providers, so the ones that are on your medical staff and the ones that you employ. We utilize the same claims data set that generates everybody's inpatient and outpatient market share data to look at, one, who are the providers that are billing claims within your service area, which helps us identify that they're there and practicing. And it also helps us identify exactly what specialty they are. And so, for a lot of physicians, identifying specialty is easy. For a lot of APPs, that gets a little bit harder, right? Because there's no centralized licensure for APPs. If you go look at any given nurse practitioner, they are likely classified as family medicine, even if they're actually practicing in a OB/GYN or a cardiology practice. So utilizing our claims data approach, we can not only identify APPs that are practicing in the market, but also segment them into the appropriate actual practicing specialty. And then we do a third set of primary research, looking at hospital websites, looking at large physician group websites. That's in some cases reaching out directly to the practice. But we're amalgamating the provider inventory by bringing together those three sets, deduplicating the data so that we have, the most accurate data that we know about each provider within the inventory, and utilizing that to help generate our, what's on the bottom of the slide, determination of net need or oversupply. So we utilize our inventory for the supply. I guess one thing I didn't comment on. So when we think about supply, we think about supply in terms of FTEs, like how are we actually practicing? So physicians, most of the models we utilize and the way that pretty much the entire industry thinks about it is in terms of physician FTEs. So when we start bringing advanced practitioners into the discussion, we have to think about, well, we obviously can't treat them the same. And even then, within specialty to specialty, advanced practitioners have a different scope of impact and truthfully, a different impact just overall on each practice. And so a family medicine, APP is going to have a very disparate impact as compared to, say, maybe a cardiovascular APP in terms of the overall productivity of the practice when we look at everything together. And so we have to make adjustments for that so that we are not over counting the APPs in that supply. So we make some proprietary adjustments there. We utilize, to think about demand, we utilize the models that are referenced directly in Stark. We think that that's the cleanest methodology. So 4 actuarial models, or 3 actuarial models and 1 kind of actual supply model. We make proprietary adjustments to those to kind of, they were all developed at different times So we make adjustments to the demand they project. We adjust them for as in your service areas, mortality and incidence of disease rates, so that it's those demand rates get adjusted based, realizing that, not picking on anybody, Southern Ohio or Northern West Virginia is a very different mortality and incidence of disease than, San Francisco, California. And so we have to adjust our models to make sure that we're, ramping up or ramping down the demand based upon that mortality and incidence of disease. And so when we mash all those things together, we contrast the demand in the market based on the population with our adjusted models, and push that against the actual supply data by specialty. We get a resulting output of FTE need by specialty and by market area. And we'll take a look at what some of those visualizations look like in a second. For most clients, we update this data yearly. So I think we've seen that kind of evolve over time, at least in my time in the industry. This used to be an every 3 to 5 year activity, which I think was maybe relevant in the early 2000s, kind of before everybody vertically integrated all the providers in their market. Probably more common now is an annual update. We definitely have some clients ask if we can update it quarterly. I think that's maybe more relevant in very large markets where there's lots of ins and outs. My personal pushback is always there's just not enough decision making that's being made quarterly to really justify kind of measuring that inflow and outflow on a quarterly basis, at least for the ROI on that. But something that is certainly doable. But again, for most of our clients, we update this data annually, and basically just start this process on an annual basis 3 months before we're scheduled to update it for you. Okay. So when we log into HSG dashboard, everything we're going to talk about through the rest of this presentation is really about the individual worksheets. And so when you log in, and here I'll pull up a live dashboard. Oh, I'm not sharing that, am I? Kelsey, am I sharing dashboard or PowerPoint still?
You are now sharing dashboard.
Okay, so when I log into dashboard, and hopefully this is kind of what it looks like for everybody. So if you go to your My Workbook section, you go to, in this case, in my demo section, it's under Strategic Growth Analytics. It might be in a different folder for you. But when we log into Provider Supply and Demand, we have a number of worksheets that can be accessed by either clicking this caret and selecting from the drop down, or similarly scrolling across the top to where you want to go to. Truthfully, I think everybody has a different preference. My preference is going left to right. I know other people in our organization like to drop down. But either way, when we're looking at this, all the worksheets, if you haven't logged into this in a while, can be accessed through that caret or across the top. And so broadly, the worksheets within Provider Supply and Demand do 3 things. One, they give us the ability to control what our market looks like. So our strategic market gives us basically all of those different market definitions that we might want to look at. And then market demographics gives us the ability to put demographic data to each of those market definitions, so that we can see population growth rates, age by cohort, median income, private insurance coverage. The next few worksheets all really focus on our supply and demand projections and different ways to look at supply and demand projections at the specialty or market level. And again, we'll go through the visuals for each of these. I just want to tee them up at a high level. So these give us the ability to drill very granularly. We can look at a subspecialty down to the zip code level, or we can take it up and look at just the need within an entire service line, say cardiovascular, for our entire market definition. And then we have a couple sheets that look at the impact of succession planning to the organization, with a particular focus on our work RVU productivity as a proxy for your existing capacity. So the common anecdote that we hear is, Well, all of my, we're starting to get the baby boomer wave of physicians that are starting to approach retirement. I have all these, 64 to 67-year-old providers who see way more patients than my, 30s and 40s docs. And it's going to take 3 providers to replace them. Well, so when we bring in succession planning data and work RVU data, we can estimate, for a given provider based upon their work RVU productivity, how many median level providers of that specialty is it going to take to replace that one provider? And that number gets kind of fun sometimes, where we really start to think, well, fun in a, not in a fun way. But we recently had a client where it was going to take 47 median level providers to replace the 30 in a given specialty that were going to be 65 plus at the end of the planning period. And that really starts to beg questions of, when we're thinking about our growth strategy as an organization and we're experiencing succession planning challenges that are that significance, what is our expectation over the next 3 to 5 years? Can we actually grow our provider complement, or is a great goal to just recruit to sufficiency to meet what we're currently able to do as providers kind of phase out of their career path? So that's what we've tried to put data to, so organizations can help size that problem. And earlier, one more thought before we kind of jump into the individual worksheets. So earlier, I mentioned, the need that the best way to make provider supply and demand data useful is to have effective market definitions. There's And so, here on the map, we kind of just drew a sample market because we didn't want to show off anybody's actual markets. But if we think about, the historic primary market that an organization might define their primary market as, just kind of outlined in this red line here, and then their historic secondary market, which should have a black line here in our legend, but doesn't. And think about it that way. If I compare this purple area up here versus this brown area down here, those might both be secondary markets within our secondary market definition. And I have a lot of clients that look at both market share data and provider supply and demand data as, one giant secondary market. Whereas, our pushback would be to make this data effective. We have to segment our market, so that we're thinking about market definitions that may kind of blend together primary and secondary, but are really more about how do our patients travel? What is our historic penetration in that market? Are we the provider of choice? Are we competing with multiple other hospitals? Or are we really trying to move into a market where our brand is not known and patients are not, we're going to have to change perception in order to get them to utilize us in a way that they haven't before. How are populations kind of clustered together, and make this healthcare decision making kind of the same way? Where do we have common competitive threats? And so, if we kind of think about all those things, segmenting our market so that we're kind of grouping areas together that we might want to make strategic decisions on makes a lot of sense for all of the market data that we're utilizing. And I know as I say that out loud, it sounds reasonably common sense, but we do see a lot of organizations where that is disconnected before we kind of come in and start having conversations, and really kind of moving to this approach of how do we aggregate zip codes or counties together, and look at that data for a given area that kind of meets this criteria. That gives us the ability to think in a lot more targeted way about how are we going to compete for patients in that market? What does our primary care or other access point footprint need to be? What do we need to think about from either a dedicated specialty presence or a specialty clinic strategy? That gives us just all of that data to really think about in a targeted market as opposed to an entire primary or an entire secondary market. Okay, So transitioning to looking at the worksheets individually. So if anybody is following along within their dashboard, these worksheets should follow along somewhat relevantly. And I'll probably jump back and forth between our PowerPoint here and a live look at the dashboard environment. So the first one I'm going to start with, and these will not be in order because I think there's a logical way to educate someone about them as opposed to work with them. So the first one I'm going to start with is this individual specialty need market map. And what this attempts to do, so if I click that, this is yours will look something like this. Again, this demo version is going to look a little bit different. But what this is looking to do is basically give you the ability to drill down on a specific zip code or on a specific geography. So for the demo version, we have counties and zip codes built in. If you have service area definitions that we've worked with you to define for your strategic market, that drop down will be available as well. So this basically says, I want to look at the dynamics of a particular specialty across multiple market definitions or across a single market definition. And so what we do there is we pick our geography. And for this, and what always defaults here is the kind of the strategic market clusters that we've developed. So I'll just leave all of these on. And then we pick a specialty. So we can pick adult primary care. What we're going to see is a few things happen. So one, this table is going to update immediately with this specialty's specific demand based upon the models and the population in that market. We're going to see the physician supply that was present within the inventory that we developed. And this is just the physician FTEs. And so what we get there is a net need physician only. So this is basically an intensity based on FTEs of need within a given market, looking at only the demand less the physician supply. And then we layer in the adjusted APP supply to get to a net need that includes that calculation for APP FTEs. So what we get here is basically a look at physician FTE need by market. Which allows us to kind of prioritize markets. And Florida is a terrible market to look at primary care in because primary care is almost a different animal than it is in almost any other state. But if we look at something like general cardiology, we can look at the relative disparity, in resources comparing markets against each other. And so if we're working on a north market strategy, we might feel much more strongly that bringing resources into that market that are appropriately supported from a referral network perspective, that are appropriately marketed, that are in a market that we feel like we can grow in, we might feel that the market demand is much less well met than it is in something like the home market where there is an intensity of resources that far outstrips the need, which means that market's clearly drawing patients in from other markets. So this just gives us that ability to kind of look at markets against each other for that specialty definition. Here on the right, this map live updates with basically all of the provider locations that were defined in the inventory so that we can see, for general cardiology, where are all the cardiology resources. And here in the bottom, this is kind of customized to how every client wants to look at it. But generally, we're trying to take, for this given specialty, general cardiology, how many providers, both physicians and APPs, does your organization employ? How many are on the medical staff? And then how many others exist within the inventory for the entire market? For some clients, they might ask us to look at that from a who else is employed by a competitor standpoint versus who's independent. Some organizations just want to know, just tell me about me and then tell me about the rest of the market. But this provider mix table basically just gives us the ability to kind of look at that provider complement kind of by alignment with a health system or lack thereof. So overall, this is the table I personally find myself utilizing the most. When I think about, trying to get into the dynamics of a different specialty, it's the one that allows us to go the most granularly And really just kind of gives us that snapshot of what's going on with that specialty in the market definition that I'm interested in. Separately, there's a specialty need by zip code map. And so when we look at this, what this does, it's the same data. It has an additional drop down, at least in the newer versions, that allows you to segment physician only need, physician only, physicians with age adjustments, and then all providers, physicians and APPs. But it basically takes that same data looking at where are oversupplies and where are needs, but it takes it down to the zip code level so that we can, kind of visually see where the intensity of provider supply is. So you can see in this given market, there's a lot of cardiology penetration, in the Southeast Jacksonville market, in the north, going up towards Georgia, in the southwest, greater Jacksonville market, and then up and down the coast. So that we can kind of just determine, where are the pockets of supply, as we're thinking about kind of our geographic strategy and where are we trying to grow to. This is just a nice snapshot to think about from a service line perspective. Where are there maybe more opportunities from a bringing care closer to home perspective, as well as just kind of thinking through the competitive dynamics of the market from an overall perspective. Separately, we have a table that's called service line or specialty need all providers. So this same thing allows us, if we desire to look at a particular geography down to the zip code level, and then to pick a given service line. So we have our own kind of service line roll-ups, based upon for each specialty, just to kind of bring everything up a level. So that if I'm a cardiovascular service line director or a cancer service line director or orthopedics, to the extent that a specialty that we would consider to be commonly groupable into a service line, we've kind of rolled up everything into a service line. So this is designed to be kind of that snapshot for a given geography. Right now it's everything. We can drill it down to a specific zip code, but it allows us to get that holistic view of all of the specialties and subspecialties within a given service line within one snapshot. So again, I tend to find that a little more useful when I'm thinking holistically about a service line, and trying to understand the supply and demand dynamics, either at the overall market level or on a drill down to a certain sub-market level. And I think it serves that need pretty well. We also have the specialty roll-up by geography table. Find that over here. And what this table does is basically gives us, and so as you may have noticed, we're kind of working from the most granular, which was that individual specialty table, to broader and broader. So specialty roll up by geography basically allows us to look at all service lines for a given market area definition. And so this is intended to be higher level, big picture, for a given market definition or for your market overall, but kind of what do the dynamics look like from each of these kind of service line level categories. Again, kind of helpful from a big picture, setting the stage perspective. Our market is very, this is the Jacksonville market. It has a lot of healthcare providers in it that are all competing with each other. So big picture, it is a market that sees pretty extreme oversupplies for most all specialties, with a dearth of primary care, and that's just largely, again, Florida is not a market. Certainly not true of the entire state, but Florida is a market that tends to be underserved from a market demand perspective from a primary care, because patient utilization of specialists, I would argue, is a little bit different than it is, at least in the rest of the eastern half of the country. And then that same table is available, but with a subservice line breakout. So this starts to get a little busy, which is why we offer the previous table. But if you want to look at kind of the individual specialties within those service lines, so for primary care, breaking out adult versus pediatric, for women's health, being able to compare, maternal fetal versus broad scope OBGYN versus urogynecology. So all of the subspecialties that we have that reported for your organization, and that might vary a little bit. So yours might not look exactly like this because obviously based upon the size of the market, the scope of the specialties you work with, for some organizations, we might, break out neurology into 15 subspecialties. And for some organizations, we might just report neurology. And it's really kind of about, how is your team thinking about it and trying not to provide more detail than your team will ever use. But again, this table is really pick a market area and let's take a big picture snapshot of what's going on in that market from all kind of our core service lines and core subspecialties. Tend to find that to be very helpful, if we're thinking about new market entry, just a snapshot of, maybe drilling that down to, a particular county that we want to look at. So we're looking at growing in this case, Nassau County. If I'm putting that in front of a executive team or in front of a service line meeting or a planning meeting, just kind of big picture snapshot. What does it look like overall from a physician supply and APP supply perspective? You'll notice in your provider supply and demand workbook, this is two separate tables because we wanted it to be snapshots rather than scroll. So the number of specialties that we track, we kind of put all core service lines on this first geography 1 of 2, and then basically medical and surgical specialties again that are not commonly grouped into service lines on a second tab. And if anybody's curious what I'm saying, not commonly grouped, so I could certainly make the case that PM&R could be included in a orthopedic service line, maybe in more of an institute model, or even in a neurological, neurosciences institute model. Pulmonary, I could roll together with a couple things and create kind of a lung service line, but I think that's kind of uncommon. And so we tend to try to shoot for what is most common when we publish data like this. So that's that. If anyone's curious, that's why it is the way it is. And then there's so that kind of takes all the major tables that are related to kind of provider supply and demand from the most granular to kind of big picture. And then we do a couple tables that as you'll see up with these worksheets are kind of these individual specialty current and individual specialty capacity. So these are succession planning and productivity focused tables that again give us the ability not only to select what specialty are we talking about, but looking at that from a geography standpoint. So I'll say most of our clients, when they're talking about this data, are using it to look at the totality of a service line across an overall market. So for general cardiology, for example, this table's doing, or this worksheet's doing 2 things. It's giving us the distribution of our productivity in that specialty as measured against the industry benchmark. So, this particular client, of their general cardiologists, heavily productive, tons of almost 50% of their providers above the 75th. So we can start to look at that as kind of that proxy for how many providers below the median are we kind of still ramping up versus how many are pretty mature in their practice, and that gives us a feel for in totality within our market, what does our kind of cardiology productivity look like? I tend to find it's also very helpful to look at that at the sub-market or less than the full market level. So if I'm thinking about maybe not general cardiology, but if I'm thinking about primary care, being able to see within our market, within our different sub-markets, within our overall market, kind of what our productivity looks like in market A versus market B. And are we still ramping providers up in market A, whereas provider B is full of nothing but 75th percentile plus providers? That gives me the ability to kind of contrast, not take away the big picture look and really kind of get into, where are we ramping people up, kind of by market definition. And then the second part of data that's on this worksheet is stratification of provider age. And again, we typically, when we do that, look at, who do we employ, who do we not employ, but is on our medical staff, And for medical staff, we typically, as you might imagine, every hospital and health system has a slightly different definition of what active, courtesy, consulting means in terms of those providers actually being present within the organization. So we try to work with you to make sure we understand, who's actually involved with the organization, and get them into that medical staff definition. But then we try to stratify those definitions across age cohorts. So we typically focus on age 65 or greater, projecting 3 years out, being those are the providers that we need to have a solution for in our recruitment funnel. We need to be very aware of what's going on in our 60 to 64 range. And generally, age 60 or less, it's a nice data point to have, but we're not going to get too excited about doing anything about it. And so when we combine those two tables together, so our stratification of productivity and our stratification of age, we can kind of combine those to say, for this particular client with this, kind of blind sample data, there's 17 clinical FTEs of physicians, age 60 or less, producing about 64% of the total work RVUs generated for general cardiology within this group. And they have another 5 clinical FTEs who are producing that are going to be 65 or older and producing 19-20% of the total work RVUs. So that gives us just a feel of how much risk do we have stratifying productivity versus age. And utilizing that kind of on a specialty by specialty basis, kind of gives us the idea of where are our challenges. And so if we then click over to the capacity sheet, so right next to it, this takes that same data and says, okay, so we have 17 providers under 60 producing this many work RVUs. If we had to replace them all tomorrow, what would that take in terms of median level FTE providers? So these 17 are producing like they're essentially 25 median level providers. We're not too worried about that because they're all under 60. They may leave the market for other reasons, but we're, reasons that would be challenging to plan around, but certainly not because of age. Whereas these 5 providers that were age 65 or older, producing about 58,000 work RVUs. So doing some quick math, that's a little over 11,600, 700 work RVUs per provider, which is pretty strong for general cardiology. And that would take about 7.5 median FTEs to replace. So that starts to give us more of the number of, okay, so if we're trying to get everyone who's 65 or older in our funnel, thinking about from a recruitment perspective, how many bodies do I have to have in that funnel? And does our organization have how do we transition volume so that we're able to ramp up those providers, to with an expectation of median or greater productivity to kind of fill that volume that we expect to be losing without losing patients or without creating gaps in access. We do that same data on APPs. APPs are a little more challenging. Not every organization is able to give us their age of APPs, which is what it is. For physicians generally at the market level, even for ones not on your medical staff or employed, you should have succession planning data within kind of the individual specialty tabs. But we don't have the same data for APP age if they're not affiliated with your organization because there's no central repository for that data. So if we look at that and say, okay, well, we have 5 FTEs that are going to take 7.5 people to replace. The first logical question past that to ask is, okay, so how much capacity do we have within our own network to absorb that volume? And so what this table, that's the second table on the capacity worksheet, is what we call provider productivity opportunity below median. And so we chose the median as basically just a generally agreeable point that providers should at least aspire to work at a median level within their specialty if they're a 1.0 FTE. And so, what we do here is basically based on your productivity data that you feed us, we identify how many providers, FTEs, both physicians and APPs, are below the median for their specialty, how many actual work RVUs they're producing, how many work RVUs they'd be producing if they were producing at the median, how many work RVUs of potential capacity that creates, and then how that translates to median level FTEs. So the way to read this would be, we have a gap of 7.5 that we're going to need to replace from a succession planning perspective. We have functionally 1 FTE's worth of capacity if we moved those providers currently under the median to the median. Similarly, you can see this organization within this sample data set has a lot of opportunity for ramping up their APPs to a fuller FTE utilization. So finding some of that access and capacity, could probably be addressed by figuring out kind of what that clinical practice model is for utilizing APPs within that specialty, a little better. There's also a couple higher level visuals related to succession planning. So if you're just looking for, within a given service line, what do the age dynamics look like? This medical staff aging by specialty worksheet basically says green is under 60, yellow is 60 to 64, orange is 65 or older. This one does give you the ability to kind of flex the date in and out. So if you want to look at everything through 2030, if you want to look at everything through tomorrow for some reason, that sheet, if you are on the most updated version, will give you that flexibility. And again, you can drill down to service line, or you can drill down to specialty on that sheet. Similarly, that data, what you don't want is big blocks with percentages, but you want the actual numbers broken out across your employed and medical staff data. The medical staff aging worksheet gives you that similar functionality, where you're able to drill down on geography for a given service line and look at all of the specialties within. Okay, so wrapping up, the last thing we want to talk about was future product updates. And so one, in terms of version updates, so we've been basically bringing everybody on board with the most current version at the time that you were brought on. So if you've had your provider supply and demand developed within the last probably about 6 months, you're on our most current version. If your last update was previous to 6 months ago, there are multiple versions that you could have been brought onto. So during your next annual update, we're going to bring everybody to the most current version, and our plan going forward is basically during that annual update, always, we're constantly iterating on, based upon our client feedback, based upon the things, that people who are utilizing this data are asking us to do. We're constantly iterating on, how best to present this data. If there's new worksheets that need to be created, we're creating new worksheets. But so we're going to continue to bring everybody up to speed annually. And the most exciting thing we have going on from a product development perspective is, launching next quarter. We're going to start integrating what we call our claims-based specialty demand model. And so, right now, we and everybody else that does this type of work, one of the models that's utilized is the US-based supply model. And so what that's doing is it's literally taking NPEs, so what are physicians and APPs licensed as, and basically creating ratios of physicians and APPs to population. And we think that's fine, but NPEs has its flaws. As I mentioned earlier, physicians change specialty, physicians aren't labeled correctly. APPs are frequently not listed with their practicing specialty. And so we've been working over the past year basically for every provider in the country to assign them a claims-based specialty based upon what they're actually billing, rolling up into an assumption about what they're actually practicing. And so what this claims-based specialty is going to do is basically look at what is the distribution of actual providers by specialty in the market, in the overall market, and then we'll be able to drill that down to region, state, county, zip code, to be able to compare, your market's dynamics versus, other similar market dynamics. It'll be something we only utilize for our strategic markets, because again, we don't want to utilize a model that we've created for Stark from a compliance perspective. But we think it'll be a model that more accurately projects, not to say our current version's inaccurate, but we think it's the next iteration of how we look at a market strategically and kind of really look at the provider supply and demand and really understand how is our market different from other markets in terms of its overall supply based on its population, based on its mortality and incidence of disease. So when we roll that out, it'll be rolled out alongside. So you'll have the ability to kind of choose, do I want to look at the historic actuarial models? Do I want to look at this new model? And as we kind of roll that out, we'll be onboarding everybody to that through our quarterly calls. We'll be looking for your feedback on, your thoughts about it. But we're excited about it because I think, I've spent 15 years kind of thinking the actuarial models should say slightly different things. And so the claims-based models give us the ability to kind of think about it in a slightly different way.